All right, well, welcome to another session for NBME Hot Topics, looking at some different topics that are high yield for NBME shelf exams and hopefully also for USMLE and clinically relevant. Set us up for what we want to discuss today and what topics you had in mind or what question you had in mind.
Yeah, hi, Dr. Body. So I think a good topic we could discuss today is some of the Parkinson Plus syndromes. So maybe we could go over each of them and specifically, multi-system atrophy, PSP or progressive supranuclear palsy, corticobasal degeneration, and then also maybe Lewy body dementia.
Yeah, so all of them are pretty relevant, and that's and I think often tested, and they are all considered or called by this pseudonym Parkinson Plus Syndrome. What do you understand by the wording plus? Why are they called Parkinson Plus Syndrome?
Yeah, so I think they all share some features of Parkinson's in terms of sort of the slowed down, the bradykinesia, some rigidity, but then each of them has some other distinct features that aren't seen in typical Parkinson's and that also set them apart from each other.
That is exactly right. So they're called Parkinson Plus because they have a lot of Parkinson's features, and then plus they have other systems involvement or other features or other abnormalities. So Parkinson's used to be the traditional name for Parkinson's disease was the extrapyramidal syndrome, where the thought was that the extrapyramidal symptoms, which is the substantia nigra and basal ganglia loop, was involved. And so involvement of that plus involvement of another system. So that other system could be cerebellar, could be frontal limbic system, on top of the substantia nigra basal ganglia system was the traditional thinking behind Parkinson Plus syndrome. But that term is starting to go away, although we'll talk about some of those diseases, but most of the experts dislike that term very significantly because it underplays that Parkinson's symptoms or Parkinsonism is present in a lot of conditions. And Parkinson Plus is only used for a few conditions, which makes you forget that so many other diseases can have Parkinsonism. So many other conditions can have Parkinsonism. So Wilson's disease and brain iron accumulation, even things like Alzheimer's and frontotemporal dementias can have Parkinsonism in them. And similarly, it also overplays the presence of Parkinsonism in these diseases. Many of these diseases that you named, MSA and PSP, progressive supranuclear palsy, and CVJD, many times don't even have Parkinsonism. So MSA has Parkinsonism only 70% of the time, and 30% of the time is just an ataxia. And we divide MSA into two types: MSA-P, which is MSA with Parkinsonism, and MSA-C, which is with MSA with cerebellar form or only ataxia. Similarly, PSP has forms which doesn't have any Parkinsonism. Similarly, CBGD may not have much of a Parkinsonism. So it overstresses on the presence of Parkinsonism in those conditions, and it understresses that the Parkinsonism can be seen with so many other conditions unrelated to them. But traditionally, Parkinson Plus was thought of these three conditions, MSA, PSP, and CBGD, because they were thought to present most like Parkinson's. And then some people add Lewy body dementia or Lewy body disease to it, and some people keep it under dementia. So Alzheimer's dementia, frontotemporal dementia, Lewy body dementia, all categorized under dementia and not necessarily as a Parkinson Plus disorder. So the modern way of looking at these is actually based on the abnormal protein that is underlying these disorders. And if you classify it that way, then there are two categories. So one category will be what we call a synucleinopathy. So alpha-synuclein. So synucleinopathy will be diseases that have an abnormal accumulation of alpha-synuclein. So that will be Parkinson's disease, MSA, which is also an alpha-synuclein disorder, and Lewy body disease, which is also an alpha-synuclein disorder. And then the second category will be tauopathy, T-A-U, tau, so tau protein. Now, classically, tau protein is associated with Alzheimer's disease, but tau actually comes in multiple forms. So the Alzheimer's disease tau is a different form. It's 4 repeats, and the 3 repeat is the tauopathy that is in these Parkinson plus disorder. So tauopathy will be progressive supranuclear palsy. It's not a synucleinopathy, it's a tauopathy, corticobasal ganglionic degeneration. And then tau is also involved in frontotemporal dementia, in addition to the Alzheimer's that I mentioned. So now you will start seeing that there is a different pattern of protein involvement, and that may be better to classify because if we're targeting treatments, then we need to target either synuclein or tau protein to target different of these conditions. So when you think of Parkinson Plus, what questions come to your mind in terms of MSA and PSP? What kind of questions come up in shelf exams or in USMLE?
I know, at least for corticobasal degeneration, I'm pretty sure like the alien hand phenomenon, I think that's sort of a buzzword. I personally haven't really learned much about that or really even completely understand what it is. I just know that's sort of a buzzword for corticobasal degeneration. I know for like PSP, they often mention like the positive, I think it's like a push test where if you have the patient stand up and you give them a slight, push, they're really off balance. And then MSA, I just know like often in question prompts, they'll mention some autonomic features, maybe abnormal or excessive sweating, urinary incontinence, things like that, in addition to, some typical Parkinson's features.
Cool. So I think what they're asking for are these keywords or buzzwords or something that have a high association with these disorders. So let's look at a few of those keywords. So let's start with MSA. The key things to remember with MSA is that number one, it has a very rapidly progressive ataxia. So it's often seen in those patients who are coming with balance problems and falls. And the most important aspect or the key element of MSA is dysautonomia or abnormal autonomic system. Now, often when there is abnormal autonomic system, that's a peripheral nerve disorder, so autonomic neuropathy. But in MSA, the autonomic problem is central, and that's why it's a central dysautonomia. And the third keyword or buzzword with MSA will be its abnormal MR finding, which is uncommon, but very striking. So let me share my screen and show you that abnormal finding. So the classic finding is what is called hot cross bun, and it apparently is or was very popular in UK. And they had these buns in the morning. And there was even songs, kids' poems, hot cross bun, 1 a penny, 2 a penny, hot cross bun. So it's a bun that has kind of a cross in the center because of the way it's baked, and creates this kind of a problem. And this is seen in pons. So at the level of pons in an MRI, you will see a cross of white matter demyelination right in the center of pons, which is considered with gray areas all 4 sides. And that is called a hot cross bun sign. It's extremely specific for MSA, but is very unsensitive. So less than 30% of advanced MSA has hot cross bun. So it is not seen in the first 3 to 5 years, and it is not seen in every patient. So you cannot rely on it for the diagnosis, but for confirmation, if you're following a patient, this could be very useful. But there are a couple of other features that are more common. Cerebellar atrophy is common in MSA. That's why it has an ataxia with it, and is probably the most common feature. And another less common but very interesting feature is this sign where you get these thin line of white hyperintensity, T2 hyperintensity, right at the edge of putamen. Putamen is globus pallidus interna and externa, or encoded. So right at the edge of the putamen, you will see a T2 hyperintense T2 line or like a rim on T2 and flare on putamen. This again is seen in less than 70% of patients, and again is seen a little later than onset, but it's far more common than hot cross bun, and we often use it more in our clinical practice than hot cross bun as a sign. So that's MSA. PSP, like you mentioned, postural instability is the most key feature or buzzword. And classic postural instability in PSP is falling backwards. So the test we do is actually pull test. So instead of pushing, we pull them. So we go behind them and we pull them and see if they can handle or not. Now, people with Parkinson's disease also develop that problem later in life, and so does MSA. But it somehow is the presenting feature for PSP and is more classic for it. But even more common feature of PSP clinically is the surprise facies, where they have dystonia of the frontalis muscle, elevated eyebrow, and often associated with deep nasolabial fold, open palpebral fissure, so retraction of the upper eyelid, and they had this kind of a deep look, very shiny face. And that surprise facies is basically a facial dystonia, a very particular kind of facial dystonia of upper face, and with a smooth, shiny skin, with this kind of a smooth, almost like a artificial made face, is very classic for PSP, often seen clinically and sometimes asked in questions or given as a hint if they are asking you to identify tau as the pathology on the exam question. And then lastly, there is also a very striking MRI finding of PSP, which is the hummingbird sign. So let me again share my screen. So hummingbird sign is also midbrain atrophy, just like Pons, hot cross bun in MSA. And in a hummingbird, you have this long beak, and then you have a head and then a big belly. And you get the big belly from the Pons, and you get head from the atrophied midbrain. So a healthy midbrain is more wider, has a thick width about it. And an atrophied midbrain is more thinner, and that leaves a lot more empty space around here, makes the belly more prominent, and then creates a long beak at the floor of the third ventricle. So that long beak, which is not present here in a normal MRI, is due to atrophy of the midbrain. So if you cut away this part of the midbrain, then you will get a beak, a head, and then a big belly of Pons. And that is the hummingbird sign of, again on T2, but this time it's in coronal slices from the middle on midbrain instead of Pons. For MSA was Pons. So that's PSP. Now, CBGD is also very unique. The buzzword with CBGD is the alien hand or alien limb phenomena. And that's a phenomena where they are unable to control their hand of one side. And that hand can do things on its own. So it almost develops a mind of its own. So it's doing reflex action. But the most striking stories that you will hear in neurology will be where the alien hand does opposite of the normal hand. So if a patient is trying to open a door with a normal hand, the other hand may actually go and close the door or fight the right hand to open the door, and almost become as under some alien's control. And that's why it's called an alien hand phenomena, where it actually starts doing things on its own, automatic behavior without consciousness that often opposes the normal side. So that is what was the most striking feature described of corticobasal ganglionic degeneration, but is not the most common feature. Alien limb phenomena is less than 30% of patients, and usually is not that striking. I've only seen one striking case of alien limb phenomena. That was from a stroke, when a lady woke up in the middle of night and she felt someone was touching her face with her hand, and she could feel the fingernails, and she got extremely scared. And then about 5 minutes later, she realized it was her own hand that was just walking on the face with a nail. So almost like an alien hand, and a very, very scary thing, and just scares the hell out of her for a while. It was from a stroke, that alien limb phenomenon. Parietal stroke can give you an alien limb phenomena. And it's the same reason in CBGD, there's a parietal atrophy that gives alien limb phenomena. But the most common feature of corticobasal, which is also very striking, is extreme asymmetry between the two sides. So in corticobasal, affects for a long time only one side, and the other side is normal. So on MRI, you actually see a hemiatrophy of the brain. So if I share my screen again and show you a CBGD brain, so you can see this is a normal, healthy looking brain, full gyri, minimal sulci, and this brain is gone. There's a lot of these lakes of CSF on one side, big lacunae as compared to the other side, which is relatively healthier, and that is a classic hallmark of CBGD. Now, there is one other disease that also does hemi brain atrophy, but is a disease of kids, teenagers. and that is called Rasmussen encephalitis. It is considered to be an autoimmune encephalitis, unlike CVGD, which is a neurodegenerative disorder. And it's a developing brain, so it's 12, 13-year-old, 14-year-old kid, usually a girl. I've seen only one case, it was a girl, which starts having very frequent, very resistant seizure. And then over a few months, you will see that the one side of the brain is dying gradually from the encephalitis, and the other side of the brain remains healthy or keeps growing, and very marked asymmetry between the two sides. And they often develop one unilateral problem with stiffness, rigidity, post-stroke kind of a feature, and resistant epilepsy. That dying brain becomes extremely resistant. Immune therapy has been tried, but nothing responds. So the whole setting takes about a year to set in, and then they are lifetime epileptic, and there's no cure for it, no treatment for it. Those are some of the striking features of all these unusual atypical Parkinsonism.
Yeah, thank you very much for that explanation. I think it was great that you also went over those images, especially because they're so striking. Like you said, those are things that, and often in questions, they'll give a little question stem, then they'll put up an image or they'll put up lab results or something, and as hints. So seeing those, definitely helps to associate them with the different conditions. So I think that was a great explanation.
Good. Let me quickly breeze through some of the other abnormal MRIs which are associated with other unusual Parkinsonism. As I mentioned, many diseases can give Parkinsonism, and I'm going to show some of the striking MRI findings which are very uncommon. Even I haven't seen them many, and I only see Parkinson's patients. So that tells you how uncommon they are. So here is the famous eye of the tiger sign. So this is what the MRI looks like, and this is somebody has superimposed an blue-eyed black and white tiger, just to show you. And what basically is that this is the globus pallidus interna, and then this is the externa, and this is the caudate. So the interna is dying. So there is a necrosis in the center, and then there is a hyperintense ring around it. So there is a hyperintensity followed by hypointensity around it, followed by hyperintensity. So almost creates a pupil and then a cornea and things like that. This is degeneration due to iron accumulation in globus pallidus interna, and that often presents as Parkinsonism in older adults. Younger kids often presents with dystonia. This is the eye of the tiger. Now, this is a giant panda sign, or giant pandas are these Japanese panda. This is midbrain, and this is the red nucleus, and all the gray matter around red nucleus, which is periaqueductal gray matter, has turned into white tissue. And with this white tissue, and then there is this preservation of crux cerebri or crura cerebri, where corticospinal fibers are going down. And this is the preservation of colliculus, usually superior colliculus around here. So the superior colliculus and crux are intact, red nucleus is intact, and all the periaqueductal gray is gone. And that is the giant panda sign or panda sign, which is a sign of Wilson's disease, so copper degeneration, presents with Parkinsonism. And then here is box-shaped ventricles due to atrophy of the caudate. Head of the caudate often projects into the lateral ventricle anterior horn, and that gives more of a moon shape or semi-moon shape kind of a presentation. But here it's becoming more of a squarish, boxish kind of ventricle. The atrophy of the caudate is associated with Huntington's disease. And sometimes they show you gross anatomy slice of a brain for the same thing. I don't know if we have it here or not. Now here is the swelling of the middle cerebellar peduncle. So cerebellum has three peduncles, superior, middle, and inferior. Middle cerebellar peduncle is basically pons connecting into cerebellum. And these middle cerebellar peduncle has bilaterality to hyperintensity. And that is a sign of FXTS, Fragile X associated tremor ataxia syndrome, often presents with Parkinsonism. Here we have hyperintensity of globus pallidus, interna and externa on both sides. Many things can do it. Elevated manganese toxicity has been very strikingly associated with it. And manganese used to be a normal part of TPN. So how you call it, where you get IV nutrition in patients who are prolonged on no restricted diet, they cannot eat because of no gut, then you give them TPN. I don't know what TPN stand for, but it was the IV mixture of lipids and carbohydrates and proteins and amino acids and minerals and things like that. And that's where often manganese was too high and was causing manganese toxicity. But there are other sources of manganese too. For example, welders can get manganese toxicity too. So this is carbon monoxide poisoning, also killing the globus pallidus antenna on both sides, and so on and so forth. So as you can see that many things can present with Parkinsonism. Unusual, these were only the ones that have striking MRI feature. Now there are many that don't have any striking MRI feature and can present with Parkinsonism. One of the common causes of Parkinsonism is medications, drug-induced Parkinsonism. Dopamine blockers is the obvious. Some are not very obvious. So antiarrhythmic drugs like amiodarone, propafenone are also antidopaminergic, and that is something not very obvious, can also present with Parkinsonism.
Very interesting. Yeah, I had heard of the eye of the tiger sign, but the other ones you showed, like the panda's eyes, I'd never heard of that. Those, I mean, that one really looked like a panda. That was that was pretty striking.
Awesome, cool. Do you have any other question related to this topic, or should we wrap it up here?
Yeah, I think you answered everything. I think that was great breakdown of all of them. You know, we sort of classified the different ways to classify them in terms of if they're alpha-synucleinopathy, tauopathy, the Parkinson features, the extra features, the striking imaging. So I think that was very helpful. Thank you.
All right.